to A&T Respiratory Lectures. This topic, obstructive sleep apnea, therapeutic alternatives, will be brought to you by Dr. Albert Ure, who is the co-owner of A&T Respiratory Lectures.
And more specifically, on these learning objectives. We'll define and describe apnea, and then more importantly, obstructive sleep apnea. We'll review some statistics, some, if you will, epidemiological statistics on the prevalence of obstructive sleep apnea. The scary thing about the prevalence is we thought it was a kind of, if you will, a boutique disorder 30, 40 years ago. Not many people had it. The more we study it, the more we find that there's more and more individuals that actually have this disorder, some of whom are probably yet to be diagnosed. And of the ones who are diagnosed, those individuals can really present some big challenges with adherence. We'll briefly review positive airway pressure therapies, describe alternatives to positive airway pressure in treating obstructive sleep apnea, review the impact of treatment. We'll take a look at a few cases, and probably most importantly is provide you guys with additional resources if you choose to drill down and learn more about these topics. It's very difficult in a little less than an hour to convey everything there is to know about alternatives and adjunctive therapy for positive airway pressure or obstructive sleep apnea. So we furnish you guys with additional resources so that you can then empower yourselves to learn more about this. And again, just become much more knowledgeable about alternatives to positive airway pressure in treating obstructive sleep apnea. So what is apnea? What is OSA? And who gives a you-know-what? Who cares? Cessation of breathing in excess of 10 to 15 seconds defines apnea. There is a range there because some books will define it as cessation of breathing in less than 10 seconds. Some say 15. There's even a few out there that say less than 20 seconds. By the way, if it's less than 10 seconds, it's known as periodic breathing, and it's one of the disorders that can affect premature babies. They often almost exclusively grow out of it. But again, if it's less than 10 seconds, periodic breathing. If it's greater than 10 to 15 seconds, it's then full-blown apnea. Obstructive sleep apnea, if the cessation of breathing is due to airway closure, and it's central sleep apnea, if it's an impaired signal from the brain, or if there's some issue with the brain is creating the signal, but there's some issue with it being conveyed down to the respiratory muscles that will facilitate breathing. Let's now look at some statistics. 50 million to 70 million Americans have sleep or wakefulness disorders. And sleep apnea affects more than 12 to 18 million Americans every year. Now, I mentioned Americans not to be totally self-focused, but obstructive sleep apnea does not discriminate. It affects folks from other countries. It affects folks that have white skin and black skin and brown skin, et cetera. It is not something that's specific to the United States. However, the statistics that I cite are those that have been compiled on the prevalence of it in the United States. Most common among adults who are basically over 45 years old and overweight. It disproportionately affects men, but can also affect women. People of normal weight and even children can get it. When I did home care full time now it's not quite, but almost 30 years ago, there were a lot of the folks were men that had short necks, they were overweight, but I absolutely set up CPAP and BiPAP equipment on patients who were men who were skinny, women who were slender, so it was, again, more commonly, heavy set men, above 45 to 50 years of age, with a short neck, et cetera, but it wasn't exclusively them. Men, however, are twice as likely to have sleep apnea than women. Women have a high chance, particularly if they become obese or going through menopause, drink alcohol excessively and or smoke. It's estimated that 4 out of every 100 middle-aged men and 2 out of every 100 middle-aged women have obstructive sleep apnea. The question is, are they diagnosed? That's really a better question. And we'll drill down a little bit more in this presentation on that. More statistics. According to the National Institutes of Health, sleep apnea is a leading cause of excessive daytime drowsiness or sleepiness. Pauses in breathing associated with sleep apnea might last for 10 seconds to 1 minute. And for folks that are afflicted, can occur dozens and sometimes hundreds of times per night. A Yale University study found that sleep apnea is associated with double the risk of having a stroke. It could also increase blood pressure, risk for blood clots, and other cardiovascular impairments. People who are obese have been found to have 4 times the risk of developing sleep apnea than people who are at a normal weight. And it's somewhat dose dependent. The more overweight you are, the higher your BMI, your body mass index, means that you are more likely, or you have a greater risk of developing sleep apnea. Individual who has a BMI of 40 has a higher likelihood than someone with a BMI of 30 or 35. A little bit of the basics on the actual mechanism for the obstruction. The upper portion of this depiction is, if you will, a normal airway. It looks like a male normal airway. And then what you see is, in B, the bottom portion there, you see that the actual uvula, but most importantly, the tongue is falling backwards. It's not a complete obstruction because there's still some patency where the lower arrow is located. But again, it's much more narrow on the bottom there as compared to the top one depicted in A. The poster child, I'm being a little bit smart here. Trying to inject a little humor. There is no such thing as the poster child for positive airway pressure in treating obstructive sleep apnea. This individual is shown as being severely morbidly obese. That's the bad news. The good news is that this individual looks like he's being compliant. He's also sleeping on his side, which is a good thing. If he adds some weight loss on top of that, and if he has issues with either smoking and or drinking, then that's a recipe for improvement. Bad news is looks like he's very severely morbidly obese. It's bad news because it doesn't just carry with it the risk for OSA, but other concomitant disorders. The good news is that he looks like he's being compliant, at least at this moment. Maybe he's being compliant until his wife falls asleep. His wife looks like she's wearing a sweatshirt or something. But in any event, maybe when she falls asleep, he whips it off and turns the thing off. Don't know. Traditional PAP therapy or positive airway pressure therapy, best case, you see this individual just, looks like very serene, sleeping. He's got his one hand under his kind of the side of his face and his chin there. He's probably dreaming these pleasant dreams, going to wake up all rested, et cetera, et cetera. It happens this way for a lot of individuals. However, for other individuals, it's less so. Again, not so best case. The person's just trying to keep the mask on. It's like, oh my God, the upper picture of the gentleman with the goatee is, yeah, am I going to do this? I can't do this. His face looks a little bit red there. He's got a headache even before he puts it on. Lions and tigers and bears are mine. The lower picture looks like his eyeballs are ready to come out of his head. So the good news is it looks like he's wearing it. The bad news is it looks like his eyeballs are going to pop out of his head, and it looks like he's going to get choked by the actual by the tubing. That doesn't really happen in real life, but you can just imagine it takes some getting used to. So there's challenges. There's challenges with people being, compliant with their positive airway pressure. I will tell you this, in one of the sister presentations to our sleep series, I actually talk about a big issue is claustrophobia. And one of the facets or one of the interventions is specifically focused on, getting the patient more acclimatized to wearing the mask, the interface. So that they can help overcome, or we can help them overcome, their claustrophobia, their fear of being suffocated and being restricted in this manner. So let's look at some of the treatments or the alternative treatments. All right. Now, I mentioned before, body mass index. So when you start getting north of 30 to particularly 35, you're talking about somebody who's not just has a little bit of excessive, body fat, maybe from eating too much around the holidays or whatever the case may be. I know that myself and my colleagues were on the front lines, like probably many of you, in treating folks that had COVID. And we had shortages of a lot of things, including PPE. Leadership presence was in short supply. So we had a lot of things that were in short supply. One of the things that was, a couple of things that were not in short supply were footwear, clogs of various sorts, and food. And a lot of us ended up, they didn't want us leaving the COVID units and spreading COVID. They didn't know what spread COVID initially, at least. So they would literally, sometimes it was the community, sometimes just the organization would just, they would bring up lunch, and they'd bring up dinner, and they'd bring up breakfast, and they'd bring up, snacks and whatever, and you just ate. So we're not talking about people that maybe put on, 10 pounds, of additional weight, around, COVID or around a stressful time in their life or whatever the case may be. We're talking about people that are severely morbidly obese. Okay. So one of the treatments, again, is weight loss. And then going along with weight loss is not just diet, but it's also exercising. So exercising can help with the weight loss or the maintaining weight. It can also promote healthy sleep hygiene. It's really talking about the cycles of sleep. That when somebody goes to sleep and goes to bed and they close their eyes, that within 5 to 10 minutes they're asleep. It doesn't always happen that way. Recently, I wasn't even feeling stressed that night. It's just like I think I had gotten too much sleep like the prior couple nights or something. I'd gotten a full 8 hours, 2 nights in a row, and then I was all charged up and I had a little difficulty falling asleep. So I got up and I watched a little TV in a different room. By the way, they do say sleep hygiene is not a good idea to fall asleep with the TV in your room there. Just passing on information. My wife loves it. I hate it. Okay. I love my wife dearly, but I don't like that particular habit that she has. But anyhow, sleep hygiene is you watch TV in a separate room. You have your set routine. If you do exercise, not a good idea to exercise a half hour before exercise, come in from a run, shower, and go right to bed. You really should have some wind down time. And you should have a similar pattern day to day type of deal. So when we talk about sleep hygiene, we're talking about not just time you're sleeping, but how you prepare, how you wake up, how much sleep you're getting, times of the day, et cetera. We find that one of the most difficult shifts to work are when you're rotating shifts, that your body, the sleep hygiene, your body, your circadian rhythm can't really settle into a rhythm. And it tends to be fragmented, and your sleep pattern tends to follow and be somewhat fragmented as well. Positioning. So sleeping in a lateral position, lateral decubitus or lateral position can be helpful. Using a contour pillow, often in addition to positive airway pressure. So we're talking about measures that can be used alone as an alternative, or ones that can be used in concert with positive airway pressure. Reduction in alcohol consumption, and just overall not drinking excessively, and in addition, smoking cessation programs. So the contour pillow, again, we refer to this in some of our other lectures as well. So it's a brand. I don't receive a commission from the company that makes this contour pillow, but basically the top line is they're showing you a standard pillow. Maybe it's one of those My Pillows from our friend who sells now pillows and sheets and everything else. And then the bottom portion there, the bottom line, are these same patients that are now getting treated using the contour pillow. Contour pillow is a contour, a contour that's more conducive to breathing for the patient, but also it accommodates the actual space and area that the interface occupies as well. So without displacing it, pushing it upward, pushing it downward, or anything along those lines. Contour CPAP pillow improves, ease of use. I sound like a salesman for this, but I'm just passing along the information that's been reported. Sleep comfort for all CPAP users. CPAP compliance, because now you have the actual interface less apt to be displaced. Neck support and spine alignment, therefore some element of airway alignment. as well as is noted here. And it reduces, that is the contour pillow reduces mask leaks, pressure on the mask and face, and overall mask discomfort. Oral appliances. So not everybody can benefit from an oral appliance. It's very important that the patient be assessed for what types of alternatives may be suitable for them. Okay. And I say that because individuals in particular who have a small jaw or who have an overbite or who potentially have a big tongue and maybe, if you will, thicker cheeks. Okay. They may or may not. They tend to benefit from the oral appliances more than individuals who have an issue that's further downstream. That's with your uvula, that's with the base of their tongue and things along those lines. It's not exclusive, okay? But it's what we know is individuals need to be assessed to see if they have, again, small jaw, big tongue, etc., and that they may be quite suitable, or a recessed chin, and a device that may, if you will, bring the chin forward may go a long way in helping them. On the contrary, if they don't have any of those things and it's much further down the airway, then oral appliances are less likely to be of meaningful use. They're custom made for each patient. They control snoring and sleep apnea by positioning the tongue and the jaw and keeping the airway open during sleep. Promote better ventilation by relieving the obstructed airway during sleep. So medications, one thing I want to be clear about. So the medications are not necessarily, they're not curing the obstructive sleep apnea, just to be completely clear on that, okay? And in many cases, what they're doing is buying time. They may be a bridge until the patient loses weight, until they get compliant with their CPAP or BiPAP, until, just, so it's one of these things where if the individual's quality of life is suffering and their job is suffering, et cetera, because they're very sleepy during the course of the day, that some of these medications can be helpful. In general, they're in a class of medications called dopamine or norepinephrine reuptake inhibitors. Okay, one of them is Sensozzi. It was just introduced. I say just, it's almost 2022, but a couple of years back. Is a once daily tablet shown to treat excessive daytime sleepiness due to obstructive sleep apnea or narcolepsy. Narcolepsy is not obstructive sleep apnea. Narcolepsy is a neurologic disorder. It's not one of soft tissue collapsing, causing obstruction. Narcolepsy is an individual could be talking to you mid-sentence and they fall into sleep. And sometimes it's caused by a lesion in the brain and the medulla and the pons. Many times it is, but not exclusively, and or some form of a chemical imbalance. So something to kind of be aware of. So Sensozzi, that's the trade name, is available in 75 and 150 milligram tablets. Does not treat the underlying cause of the OSA, as I said a little earlier. It does not take the place of any device prescribed for OSA. Such as continuous, CPAP or BiPAP or anything along those lines. For many, Sensozzi did improve, so it's been studied. It did improve wakefulness for up to 9 hours and worked in as little as 1 hour, in measured over a 12-week period in 2 clinical trials. There's actually been more clinical trials that are in the process of getting published that support its use as well. Sensozzi was not shown to cause symptoms of withdrawal or dependence in any clinical trials. So something to kind of hip pocket information. This whole presentation is really talking about alternatives and adjunctive therapies in treating obstructive sleep apnea. So if I did not include this, I would really not be, I would be remiss in the mission of the presentation. Other CNS stimulants or central nervous system stimulants. There's modafinil, 200 milligrams a day. Others that I've listed here, armodafinil, 150 to 250 milligrams per day. They don't come to us with no side effects. They do have some headache and nausea. Other side effects can include anorexia and others that are listed here. Other considerations, so use with caution. So these stimulants can also cause vasoconstriction, also cause an increase in heart rate. So they need to be used with care with individuals who already have angina, particularly if it's not stable angina. Cirrhosis, because all of these substances are broken down in the liver. So if an individual has cirrhosis or other, a fatty liver, where the liver needs to then detoxify or break down the substance, you're then taxing the liver more. Kidney disease, high blood pressure, heart disease, history of heart attack, history of mental illness or psychosis, history of alcoholism or drug addiction. It is not known whether this medicine will harm an unborn baby. So basically, if someone is pregnant or trying to become pregnant, good idea to, at a minimum, consult the physician, and at a maximum, consider not actually taking the medication at all. One of the other things that individuals need to be aware of is these medications as a group may make certain childbirth control hormones less effective. So that's obviously very relevant. It's not saying it's going to harm an unborn baby, but it's saying that if you're taking birth control, you don't think you're going to get pregnant, it can affect that as well. And the broader point is any medication that you're taking can affect another. So just really need to, even some, herbal supplements and things along those lines, you need to tell your healthcare professional all the substances that you're on. Some natural supplements, speaking of herbal, etc. So ensure adequate vitamin D. So what we're really saying is, it's not that vitamin D will make people sleep better. Pardon me. That's not what we're saying here. What we're saying is that if the person is deficient in vitamin D, if they have a deficiency, that it can further, if you will, the apnea. So they're recommending 2,000 to 5,000 international units per day. Magnesium is another one of these, these substances that if an individual has insufficient magnesium, it can affect their sleep. So they're really saying supplements can go a long way. Certainly there are some side effects, diarrhea being one of them. Magnesium is also a bronchodilator. I'm not suggesting, by the way, that it would be taken exclusively for that reason, and then there's this 5-HTP, which is a precursor to serotonin. And it's just one of these things that can actually, taken along with magnesium, can potentiate the effects, can basically result in more serotonin in the body, which can further promote a better sleep hygiene and pattern. Other homeopathic substances, and again, covering this for the sake of completion, not necessarily, not trying to say that chamomile tea is going to transform someone's life, but you need to be aware that it's one of the simplest natural home remedies for sleep apnea is a cup of chamomile tea before you go to sleep. So it's maybe you're doing weight loss and chamomile tea, so there's combining different approaches while you're in the process of losing weight, trying to see if the interaction with all of these, changing your sleep position with several of these measures can collectively help the individual out. Substances found in chamomile tea are believed to help relax nerves, which make it easier for individuals to fall asleep. Almonds, among the best natural home remedies for sleep apnea. Again, small ingredient can help supply the body with a high amount of magnesium, going back to that again, which enables the muscles to relax more. Turmeric has anti-inflammatory qualities. It is claimed to fight against inflammation that can take place in the respiratory system. So this is really more, if someone is having irritation, maybe even having irritation associated with the positive airway pressure and the dryness, etc., it may be a good complement to that in order to kind of fight that inflammation. We'll reduce the times you stop breathing at night, and mixing it with warm milk have one of the best natural home remedies for sleep apnea. Now, again, I'm claiming that the literature talks to this, and there's been a limited number of small studies that have supported that it will give a therapeutic advantage. It's not curative, but some of these approaches can give a therapeutic advantage over not taking these approaches. A newer form of treatment is known as upper airway stimulation, UAS. So I will tell you that I 2 editions ago, so it must have been edition 8 for my clinical assessment textbook. I was working with an individual on a chapter on sleep, and he bailed on me. I just bailed. These things happen. So I am not a polysomnographer. I'm not, a poem crit care doc. I'm not, none of the above. I'm pretty well read. I know how to search the literature, etc. I do have some physician colleagues who really, are very deep in interpreting sleep studies, that sort of thing. So in any event, I took the chapter over. I was the section editor, and I was kind of, went around a little bit. And long story short, I ended up editing a chapter, and I felt a little bit out of my territory. The chapter ended up being fine, but it was a lot of work. And in the process, if you want to get really knowledgeable about something, it's, I would say at a minimum, give a presentation like Terry and I and our guest lecturers do. It's going to force you to research a topic and drill down more, but write a paper on it, write a book chapter, write a manuscript, etc. And it's going to force you to become a lot more knowledgeable. And in writing this chapter or editing this chapter in like 2000 and mid 2010, 14, 15, 16, in that era, I initially stumbled. It's now much better understood, but I initially stumbled over a study that was done by Strollo. I think Strollo was out of the Cleveland Clinic, and he basically, it was a small to mid-sized study where individuals who had significant comorbidities, okay, so they had not only under or untreated obstructive sleep apnea, but they also had high blood pressure. They had, some other cardiovascular risks. They had diabetes, et cetera. So they had a lot of these moving parts going on here, and they had obstructive sleep apnea, and they could not tolerate positive airway pressure. So they had this combination, this bad combination, where they have all these comorbidities. They're seemingly connected to the obstructive sleep apnea, these comorbidities, and they can't tolerate the mainstem therapy of CPAP or BiPAP. Okay. And what Strollo did was he and his colleagues applied this upper airway stimulator therapy that was under investigation under design and investigation by his team previously. And if you look at this slide, you look at the lower right-hand portion of the slide, you actually see a device. So it's the implantable pulse generator. Kind of looks maybe a little bit like an implanted pacemaker or defibrillator. And it is about the size of that, by the way. So it's placed on, kind of under the muscle flap there. It has a sensing lead to sense when the diaphragm is contracting. It senses that, and then it sends a signal to the generator that then sends an electrical impulse to the upper and will contract the muscles. It will increase the muscle tone, cause them to contract. By doing all that, causes the airway to open up. The difference or the effect of the intervention were demonstrable, where these people had both objective and subjective measures that improved. So objective were things like when they had a subsequent sleep study that their apnea hypopnea index was much lower, that they basically had a demonstrable less apnea, and the apnea they had was not as severe. And there's the generator can be adjusted. The signal can be adjusted. So they found that, but they found that the individuals they said, I feel better. I don't have headaches in the morning. I'm more functional. I'm not depressed. I'm not falling asleep. I'm not. So they had this, I'm reporting subjective results, but also these measurable ones as well. So it was kind of a big deal. And again, now in Inspire 2, it's been popularized. So here we are, almost 2022, some, roughly 6 or so years later, and it's really been popularized. Let's talk a little bit more about this. So you actually have, again, another different depiction here, but on the left-hand side, you have kind of, the sensor, the generator, and then the actual stimulation lead. And then you actually have the actual controller itself, okay, where you can put it, you turn it on, you can put it on hold, okay, turn it off. And then another depiction there on the right-hand side, which just kind of shows you just from a different angle, how how it's actually kind of laid out, and you can see it goes under the skin, etc. I will tell you that there's been a limited number of cases where there's been problems, not life-threatening problems, but where individuals they thought they were turning the device off when they woke up in the morning, and they paused it for 10 minutes. And now they're going into shave, and now the thing starts sending a signal because it senses breathing. So, it's just devil's in the details. If number one, it's not tolerated it's well tolerated overall, but not tolerated by everybody. And it also needs to be used properly, and it may need to be adjusted as well, the actual settings. A little bit more on what it looks like. They're developing, as far as coming up with better, iterations of it. But it's, again, 5 years ago, it was, oh, I kind of heard of that. Now it's, a lot of people are starting to know somebody who's actually used it with some success. Works completely inside your body. A little bit more of what they, less anecdote, more what the studies are claiming. So your natural breathing process. So it senses when you're getting ready to inspire, when you're getting ready to breathe in. Small devices planted just under your skin, actually under the actual flap of, could be adipose and or muscle, in a short outpatient procedure. So you're not, most patients are not required to be hospitalized. Delivers a gentle, it's a matter of opinion, but a gentle stimulation to the upper airway during sleep, allowing your airway to remain open when it needs to be open. Simply turn it on with the Inspire Sleep remote, which I showed you in the preceding slide, before bed, and off when you wake up in the morning. And again, the reason why it has a on hold is an individual may get up in the middle of the night to get water, or go to the bathroom, or answer the phone, or whatever the case may be. You want the ability to put the thing on hold and have it resume. Upper airway stimulator. So a little bit of the research, again, Strollo and others in the New England Journal of Medicine. It was 2014, but it was really it was really one of those transformational articles. It came out and people were like, wow, this is potentially a game changer. So it was multi-center, meaning it was done in more than one site. It was prospective, so they were moving forward. They weren't looking back at medical records. It was a single group, so it wasn't compared. It was a single group of individuals, a cohort design. Okay, so these were folks that had to have demonstrable OSA, that was not responsive to other things. Surgically implanted in 126 patients with OSA who did not tolerate, for various reasons, CPAP or BiPAP therapy. In this uncontrolled, we're talking about, there was an experimental group, but not a control group. Upper airway stimulation led to significant improvements in objective, I referred to before, AHI scores, and subjective measurements. And then there's been additional studies as well, such as this one by Seuss and others, 2016. This was a stronger, it was prospective, multi-center cohort, moderate to severe obstructive sleep apnea patients. The patients, again, they were talking about some of their body mass index was, north of 32. And then they used the stimulator, had it implanted, and they found that it can provide significant improvement in important sleep-related quality of life outcomes, et cetera, et cetera. The effect is maintained. That was the big deal. Maintained for, again, the 2-year study follow-up period. And there's been studies since then, or the cohort study means the study continued, and they found that these results have been sustained. And there was also another study that looked at, actually, I stand corrected, it was a case study. So a single case of an individual who had both the Inspire and had a implanted defibrillator, to see if they interfered with one another, and they did not. Now, this was one case. There's been a few others that have been published since that say it looks like they're very compatible. Just something to kind of stick in your hip pocket for now as well. Another approach is what's called the night balance Lunoa by Philips, formerly Philips Respironics. Philips. The principle behind this is that it's to encourage a particular position, body position, so that the individual, again, it can when they're sleeping in a side position and they roll over on the back and they start snoring, they have more apnea, that they're stimulated to wake up and go back into that sideline position. So again, a little bit more granularity. It's mask-free treatment that helps you, the patient, stay in a side sleeping position to reduce breathing disturbance. Now notice, not necessarily going to cure the patient, but it may be one of these things that when combined with weight loss, combined with reduction in alcohol, may well result in a meaningful improvement in the patient's condition. Clinically proven therapy for positional OSA been found to be non-inferior. That's just a term that they use in certain research circles. Non-inferior to PAP therapy. So it's found to be, at a par with PAP therapy. Now, what I was going to say is this, is that everybody's different, okay? And, I'm not saying that this is one that should replace PAP therapy, whatever, but it's something, it is an approach that should at least be considered in the arsenal of alternatives to positive airway pressure to treat OSA. That is what I'm saying. It is a palm size, compact, discreet, small, well-tolerated device that is worn comfortably across the chest in a soft, adjustable belt under your night clothes. During sleep, it delivers auto-customized gentle vibrations that prompt you to move off your back and move onto your side without disturbing your sleep. I guess it's debatable. It disturbs you enough to kind of wake you up to move, but not enough to disturb your sleep. We can debate that to a blue in the face. The bottom line is really that it was found to offer some real benefit to individuals and maybe a viable alternative to positive airway pressure. There was a piece that was out, again, by McKay. And I rarely take like a screenshot of an article and pop it in the middle of a presentation. But I put this in here for a reason. It really talks about the surgical approaches to obstructive sleep apnea. Okay. Now, I've kind of started real conservatively and I've kind of worked in a more invasive direction. All right. So, we started off with the weight loss and the positioning, et cetera, et cetera. And then we kind of went to, well, there's a device that can go under the skin, there's a belt that can go around. And now when you start getting to the approach where you're considering some form of surgery, you're getting extreme. I'm not saying it's something that shouldn't be considered. It's just getting more extreme. But for those individuals, this piece that was published, okay, can really, it's a must read. And again, it really just gives a nice synopsis of the different surgical approaches to treating folks that have OSA, when those approaches should be considered, when they should not be considered. If you have an individual who has a demonstrably small jaw and they don't tolerate, positive airway pressure, or it doesn't fix the problem, they don't tolerate a dental appliance, or it just doesn't work, but they're still with significant comorbidity and disability, then perhaps surgery is something that should be considered. This article talks all about that. Let's take a closer look. So one form of surgery is a tonsillectomy. I mean, I had a tonsillectomy when I was like 3 years old, I believe. Some individuals go into their adulthood. Tonsillectomy tends to be a bit more of a deal in adults than it is with kids. Because the anatomy is smaller, it's more pliable, et cetera. But it's something that, if you have that extra tissue there, particularly if it gets swollen because of allergies and infections and that sort of thing, it can be one of the potential barriers. So they're actually, this particular picture showing you an individual who's had a tonsillectomy fairly recently. Again, UPPP, okay. I mean, short known as a uvulectomy, okay, but it's basically the uvula, what we used to call when we were kids, the punching bag in the back of the mouth. What the UPPP does is it usually with a laser is they're going to laser that off. That's very well innervated tissue, so it can be something that causes a lot of pain and discomfort and some swelling on the negative side of the equation. But it can also help individuals, particularly individuals who are assessed as having an exceptionally large uvula. Again, the procedure is used to remove excess tissue in the soft palate and widen the airway. May also be effective in mild to moderate cases of obstructive sleep apnea, as is shown in these figures. Now we're getting even more drastic when we talk about the actual surgery, because the the maxillomandibular advancement surgery, or MMA surgery, where the upper jaw and the lower jaw are lengthened and moved forward. Okay. The translation on this is that the lower jaw in particular is broken. They would actually saw it, break it, and advance it. So you got to think about, the patient would have to be very symptomatic with a lot of comorbidities, a lot of things going on with regard to comorbidities that are associated with obstructive sleep apnea that are affecting the patient's health status, et cetera. But in extreme cases, this is something that's in the arsenal. So again, just something to think about. Tongue reduction surgery. Tongue reduction surgery is another approach that's out there. So it may be helpful when the individual is assessed in advance and they're determined to have an abnormally enlarged tongue. Tracheostomy is a last resort. Now, I recall giving a presentation a long time ago, and it was a live presentation, and somebody in the audience was just aghast, thinking that I was recommending that individuals that have OSA have a tracheostomy. And all I said was, I'm not recommending this. I'm saying that for individuals that have, a severe ensemble of comorbidities that affect their health status, and they've failed all other approaches, it's something that at least should be talked about. Okay. And I remember as a neophyte contributor to Egan's Fundamentals a long time ago, one of my mentors, Dr. Craig Scanlon, who was the 5-time editor of Egan's, and when I worked with him, he taught Terry and I, but when I worked with him at what was then the University of Medicine and Dentistry and later Rutgers, Craig got us involved in, got me involved in editing chapters from Egan's early on when I was a junior faculty member. And he had me involved in an Airway chapter. And I remember reading this in the chapter. I'm like, wait a minute, we would actually do a tracheostomy on a patient who has obstructive sleep apnea. And he said, Al, it's not commonly done at all for that. It's absolute last resort. Are there cases where the patient's been tracheostomized because they had a laundry list of comorbidities associated with obstructive sleep apnea, that it was just affecting their health in many, many ways, their utilization, their quality of life, their family's quality of life, et cetera. So it's one of the things that's not at all commonly done, but on very rare occasions, it can be done in order to alleviate the obstruction. So let's look at some take-home points here. So the bad news is obstructive sleep apnea is widespread. It's a widespread condition. And one of the things, I alluded to this very early on when I talked about the epidemiology, is one of the things that's really upsetting is it's like the more individuals we screen for, sleep studies, for even doing like a stop bang or overnight oximetry, we find that a fair amount of them have, roughly 5% of our population have obstructive sleep apnea. Could be higher than that. That's an estimate, by the way. All right. So you say, well, it's not really a big deal. Well, when you look at the news, so let's just put aside diabetes, depression, high blood pressure, stroke. Let's put that aside for a minute. There are cases out there, more than one or two, where there's a major train accident that results in loss of life, limb, and property damage. Big time. Okay. There was one that happened in Manhattan about 3 years ago, but they happen. And when they drilled down, they have found that more than once, and a disproportionately high percentage of the time, the person in control, the pilot, okay, the driver, even though a lot of this stuff is automated, the driver of the train was found not to be under the influence of anything, and indeed was previously diagnosed with obstructive sleep apnea, and they were not being treated, or they were not compliant, or some combination thereof. So, so that's so well understood now that the Teamsters, truckers, okay, if you're a trucker in the United States and you're a Teamster, part of your criteria for employment is you need to have sleep study. Now, I've heard of stories where individuals who know they have OSA, but they still want to drive the truck, they have, the equipment is sent, the polysomnogram equipment is sent to the patient's home, and they put it on the wife or something along those lines. Or if the wife's the truck driver, put it on the husband, who doesn't have OSA, whatever. So there's been these kind of end run things. But you think about it, we're talking Teamsters, union, one of the most powerful unions in the country, has actually agreed, and they did it, a decade ago or more. They've agreed to have their truck drivers tested, knowing that there's been such loss of life and loss of cargo and trucks, etc., that this is something that we're going to totally buy into. So it's a little scary. It's a little bit daunting. And again, I'm playing that mixed bad news, good news. Bad news is it's widespread. There's probably a lot of undiagnosed cases. There's probably a lot of cases that are diagnosed where the patient is not complying with the therapy. That's the bad news. The good news is we have an arsenal. We have, and every year, every 2 years, every 3 years that goes by, we have more and more tools in our arsenal. That's the good news. The consequences of obstructive sleep apnea are much more than simply daytime sleepiness or somnolence. We know that. And again, stay tuned for our other presentations where one of my other ones I drill down, talk about the research, talk about the specific types of conditions which can be either caused or worsened by obstructive sleep apnea. And again, things like diabetes, or if you have diabetes, it becomes more resistant to insulin, stroke, heart attack, high blood pressure, depression, anxiety, car accidents, etc., industrial problems, people that are just missing work. When I did home care, I had one individual who had a Snap-on tool group, Snap-on tool franchise. It was his. He bought it. He was working it, and he got to the point where he couldn't work it because his obstructive sleep apnea was so far out of control. He was missing appointments. He cracked up a truck. They actually, Snap-on, because they have provisions for this sort of thing, took the franchise away from him. I think they bought him out, by the way. But they said, you're not selling because you're not out there because you have this problem. You need to get this problem fixed. And, in the meantime, and I was saying it was sad. I was very hope that he eventually did manage to get his franchise back, or his business back, but whatever. So it has these very significant, it's not just health, it's also in some cases people's way of life. However, obstructive sleep apnea is treatable, and obviously positive airway pressure is still the mainstay. It's still a important if you will part of our arsenal in combating this condition. Many people can't tolerate PAP. That's the reality. It's, again, 100, 120, 90 liters per minute going into the patient's face. Sometimes it's fairly dry air. The interface may, irritate the skin, break down the skin, etc. So it's not a surprise that it can be difficult to actually tolerate. However, there's alternatives. And this presentation was really focused on those particular alternatives, some of which have been around for a while, others which are pretty new. And kind of nice to kind of see, some of the tried and true, some of the things that were introduced a decade ago, and some other approaches that are, only a few years old. Alternatives should be tailored to suit the individual. I'm not touting, dietary supplements, whatever, just aimlessly. Okay, I don't necessarily think that they're going to be transformational in and of themselves. I think when combined with other approaches, they may offer some hope as well. However, much more work has to be done. If you think about the developments that have been made in the past 10 and 20 years, and even in the past 5 to 6 years, think about what's going to happen over the next 5 and 10 years. There's going to be more work that's going to be done, and probably some more success for folks that are afflicted with this condition. Some selected references are here. One of them is Egan's Fundamentals, the 12th edition, which includes a chapter on sleep medicine. It also, throughout the textbook, there's very relevant elements, including a chapter on non-invasive positive pressure ventilation. And obviously we talk about, the CPAP for OSA in that context as well. My clinical assessment textbook, formerly done with Craig Scanlon and myself, and now I'm writing solo on the 9th edition, which just was released. And a chunk of which was actually written during the COVID surge. It's crazy times. And if you're looking for the actual cornerstone textbook for sleep medicine and polysomnography, it would be Spriggs. And the 3rd edition of his text came out in 2020. And I've listed some other here as well. With that, I really want to thank you guys for joining me today. Hopefully you got something out of the presentation and the other presentations that are within the sleep ensemble, as well as the other offerings that A&T have on the market as well. Thank you. Have a great day, and we hope to see you again. Bye.